Hello and welcome again to today's webinar on preparing for the upcoming claim reviews on eye injections, and specifically the eye injection for Eylea and Lucentis, which will be conducted in our J5B jurisdiction. But even if you are in J8B, it doesn't mean that you are maybe not going to be included somewhere down the road. So the CPT codes that are going to be included in this review are those listed on the screen here. The J0178, J3490, J3590, or C9399, as well as the J2778. My name is Mary Sue Gardner, and I'm going to be your presenter for today's call. And I'm joined today by Jennifer and Rachel, who are the other nurses on the Provider Outreach and Education Department team that are going to be helping me with the question and answer portion. So on your screen right now is our disclaimer. We show this disclaimer during every event that we conduct. As stated on the slide, this education is prepared as a tool to assist our providers. It was prepared with the most current Medicare laws, rules, and regulations in place. However, Medicare laws, rules, and regulations often change. As a provider, it's your responsibility to make sure you're following the current laws, rules, and regulations. Any answers that we give to questions today will be based on what the current laws, rules, and regulations are today. So again, if they change tomorrow, you'll need to make sure you're following whatever those rule changes are tomorrow. Also, CMS prohibits you from recording this event for profit-making purposes. We don't know your intent of why you would be recording, so if you are recording, we ask you just to stop that. But as I stated previously, we are recording this event for you, and the encore of this event will be available on our YouTube page in the next week or so. My objective for today's event, especially for our J5B providers who will be coming under review, is to help you minimize your risk of denial of these services, as well as ensure that your practice is prepared to meet Medicare's requirements for coverage. And I hope to accomplish this today by discussing the conditions of coverage surrounding these codes, reviewing compliance protocols and Medicare expectations, going over the documentation requirements to help support the medical necessity, and finally, allowing time for questions and answers on the topic. So this page is just a list of acronyms. These are acronyms that I may refer to during the course of the presentation. If I happen to say something that you don't recognize or use an acronym that you don't recognize, just refer back to this page. For those of you that are participating that are non-clinical, let's first discuss what the intravitreal injection is. It is a procedure done to place a medication directly into the space in the back of the eye called the vitreous cavity, which is filled with a jelly-like substance called vitreous humor gel. During this procedure, a healthcare provider, and that's usually an ophthalmologist, injects medication into the vitreous near the retina at the back of the eye for treatment of these conditions that are listed here on your screen. Excuse me. And to help protect the patient's vision. So this method is most often used to get a higher level of medicine directly, to the retina area. Eylea and Lucentis are both types of medications that would be placed in the vitreous space. And those are used again for the treatment of neurovascular or wet age-related macular degeneration, which I'll probably just say AMD, diabetic macular edema, diabetic retinopathy, as well as a few other conditions. Excuse me. So why are these procedures performed? Again, usually in any of these conditions, it's to help lessen the effects or improve the vision of these conditions. With macular degeneration, that's an eye disorder that slowly destroys the sharp or central vision. So when you're looking at what would be right in the central vision. Macular edema, that's swelling or thickening of the macula, the part of your eye that provides sharp central vision. Diabetic retinopathy, that's a complication of diabetes, which can cause new or abnormal blood vessels to grow in the retina, and that's the back part of the eye. Uveitis, that's swelling or inflammation within the eyeball. And retinal vein occlusion, that's a blockage of the veins that carry blood away from the retina and out of the eye. And then there's, also I'm going to screw that one up. This one, but that's an infection inside the eye. So in today's event, we're really going to focus on those two specific injectants that we talked about and why we're going to be reviewing claims for this service. These HCPCS codes are reimbursed by Medicare under a global surgery package for minor surgery. So this includes services related to the preoperative, the intraoperative, and the postoperative periods. So let's go ahead and move on and discuss really why we're here, how we got here. So keep in mind, Medicare Part B covers ophthalmology services that are reasonable and necessary and for the diagnosis or treatment or illness or injury or to improve the functioning of a malformed body member. So ophthalmology services under Medicare include these intravitreal injections, and specifically Eylea and Lucentis, and they're used to treat those eye disorders that we had talked about. Medicare pays for the intravitreal injections, again, as part of that global surgery package, as long as the administration of the drugs is done in accordance with the FDA-approved schedules. The Claims Processing Manual, Chapter 12, Section 40, states that separate payments can be made for other services provided by the same physician on the same day as a global surgery if the services are significant and separately identifiable or unrelated to the surgery. In our review, we will review claims for the intravitreal injections of Eylea and or Lucentis and other services billed on the same day as the injection. So that includes like evaluation and management services. And we're doing that to determine whether the services are reasonable and necessary and meet Medicare requirements. So again, how did we get here? How do we decide on this? Well, prior OIG work found that Medicare inappropriately paid for services that were being that were billed as being distinct or separate or separately identifiable from other services on the same day. Excuse me. The The data analysis in this case from the OIG actually showed that in 2018, there was a specific ophthalmology clinic in Florida that was part of this study that they looked at that frequently billed for other services as being distinct from or significant and separately identifiable from the intravitreal injections of the drugs, and they were looking at Avastin, Eylea, and Lucentis. So their objective was to determine whether the clinic complied with the Medicare requirements when billing for these injections, as well as other services provided on the same day as the injections. The audit covered Medicare Part B payments of $2.1 million for the intravitreal injections and other services that were provided on the same day that just this specific clinic provided in 2018. So they reviewed a stratified random sample of 100 beneficiary days consisting of 543 services and drugs. So a beneficiary day consisted of all the services and drugs provided on a date of service to a beneficiary in which the injection was administered. So for each sampled beneficiary day, the clinic provided copies of the medical records to an independent medical review contractor to determine whether the services and the drugs were properly billed. What the OIG found is that the clinic complied with the Medicare requirements for billing the intravitreal injections. However, the clinic didn't always comply with the Medicare regulations when billing for the other services provided on the same day as the injection. So all 100 sampled beneficiary days included at least one service that did not comply with the Medicare requirements. For 317 of the 543 services and drugs associated with that 100 sampled beneficiary days, the clinic complied with the Medicare requirements. Excuse me. However, for the remaining 226 services, the clinic did not comply with the requirements. So 156 services were not separately payable, and 70 services were just considered not medically reasonable and necessary. So from this, the OIG recommended that the clinic refund the money to their Medicare contractor, and the money estimated was $215,000. That's what they estimated in overpayments for the services provided on the same day as the injections. They also recommended that the clinic implement some policies and procedures to ensure that, they are in compliance in the future. So many times when there's findings like this with such large amounts, then there's a trickle-down effect. And that trickle-down effect comes down to the MACs to start analyzing data of their own providers and looking for similar high utilization of, the same types of service. So WPS ran analysis for the use of Eylea and Lucentis, and from that analysis, we've then decided that, yes, there is significant enough evidence to perform upcoming claim reviews. So before we review a little history on FDA approval of these drugs, let's review some of the basic coverage criteria for their use. So in order for providers to utilize these medications for treatment for your patients, you must ensure and document, that's the key, and document that the services are provided only for a covered condition In the next couple slides, we're going to go over those FDA approved and covered conditions. Another condition of coverage is that the medication is administered per the covered dosing units and schedules. So those are contained in the article on our website, which we will take a peek at later, pending the amount of time. And in there, you can find the FDA package inserts that include the administration instructions for the drug. The insert, again, contains the dosing schedule for the drugs and how much and how often they should be administered. At this time, WPS, we do not have an LCD or an LCA on these drugs. So providers must follow the Medicare guidelines as well as the FDA approved guidelines and dosing schedules for their use. Finally, make sure that when you bill the claim, you are billing with the appropriate CPT code, the appropriate units for the amount administered, as well as any necessary and appropriate modifiers that need to be on the claim. So this would include any cases that require a modifier for a possible NCCI edit or a frequency and global surgery guideline, eye modifiers such as right or left, and when necessary, the separately identifiable services such as when you would use modifier 21. If you're doing the E&M service as well, if it meets the guidelines. So let's move on to some of the specific coverage conditions for these drugs and a little bit about their FDA approval. All right, so Eylea is the first one that we are going to talk about. And so starting back in November of 2011, Eylea started to receive FDA approval for its use. So it is I'm going to say this, a VEGF inhibitor or an anti-vascular endothelial growth factor. So that's a lot. So I'll probably just say anti-VEGF in the future if I have to use that again. And it's indicated for treatment of patients with wet AMD, macular edema following a retinal vein occlusion, diabetic macular edema, diabetic retinopathy, retinopathy of prematurity. So it got its first FDA approval for use in wet AMD in November of 2011. It then continued to receive FDA approval for use of diabetic macular edema in July of 2014, and macular edema following retinal vein occlusion, or RVO, in October of 2014. And in 2015, it received FDA approval for diabetic macular edema. And finally, in 2019, diabetic retinopathy. The FDA also approved injection dosing schedules for wet AMD in 2019. Finally, just this year, it was approved as the first pharmacologic treatment for preterm infants with retinopathy of prematurity. All right, so the dosing information for Eylea is listed on the slide. And since that schedule is provided, I'm not going to read it to you. What I do want to stress is the importance of the documentation that you keep following the dosing amounts and the schedule. As a review contractor, we're going to look at your documentation for the drug provided. The drug name should match what is billed on the claim, so it must match the CPT or the HCPCS code that you bill. And next, we're going to look for the condition for which it's being administered. Based on the condition it's being used for, we're then going to check your documentation for the administration history. That history must include the drug, the amount, the date, the site, and the patient's response to treatment. It's important that whatever date of service we request for review, that you're also providing us the history of all the other treatments so we can verify that you're following the approved amount and dosing timelines. So again, as I said with the prior slide, I'm not going to review all these dosing guidelines with you because they are in those package inserts. However, it is your responsibility as a provider of the services to make sure you're following those correct dose and administration guidelines for the condition that you're treating, and to make sure that they're clearly documented in your medical records. So we'll move on to Lucentis. And if I butcher these names, please excuse me. I don't obviously dabble a lot in eye medications. So, all right. So much like Eylea, Lucentis received FDA approval for various conditions throughout the years. So starting back in June of 2006, Lucentis received FDA approval for treatment of wet AMD. And then in 2010, it was approved for macular edema following retinal vein occlusion, and then for diabetic macular edema in 2012. In 2015, approval was then given for treatment for diabetic retinopathy in people with diabetic macular edema. Then in 2017, FDA approved Lucentis for myopic choroidal neurovascularization and all forms of diabetic retinopathy. Again, as a review contractor, we're going to be looking for the diagnoses you're administering the drug for, and if that diagnosis needs to be for a Medicare covered condition. So just as I stated with Eylea, the dosing information, I'm not going to read this to you. It is available on this slide, and it's available in those drug packet inserts. One thing I do want to point out about Lucentis is there's a provision under the once-a-month guidelines. So you can see, like, for macular edema following the RVO, 0.5 milligram once a month. There's a provision under the once a month that is approximately 28 days. So what does that really mean? It means that the provider has the flexibility to inject every, 26 days, 28 days, to allow a 2-day variance. And that's for like a holiday or a weekend or office closure, et cetera. So the cutoff is actually 26 days. However, claims billed within 25 days of the last injection, the system is going to automatically deny those. So we will accept bills after, following that 28-day guideline, it's called. Read the instructions for the package insert. Excuse me. That's where you're going to get your most information. Just make sure you're following those dosing guidelines for the drug that you are using. All right, the scope of the review. So why are we doing this? We already discussed. There was OIG findings. Those OIG findings have trickle-down effects. We as a MAC decided to review the data of our providers that were billing for these drugs as well as other separately identifiable services on the same day. And we are going to start claim reviews, targeted probe and educate reviews of those coming up. Again, it'll start specific to our J5 Part B providers. And we're going to really be looking at you're providing and using those drugs for a Medicare-approved diagnosis, a FDA-approved diagnosis, that you're administering them based on the appropriate administration schedules. And if there is anything that's separately identifiable, that it is billed appropriately and it contains appropriate modifiers when necessary. The approved diagnosis should be supported by the documentation and not just by the billed ICD-10 diagnosis code. So the documentation should support the actual name and amount, et cetera, of the drug administered and how that administration schedule aligns with the FDA approved schedule. So again, the services billed on the same claim as these drugs that are included in the global surgery packet, such as CPT 67028. Those will not be separately reimbursed and may result in a partial denial of claim. I'm going to have Jennifer place a link to WPS GHA article on the review, that has information about this review process. I'm going to have her put that in the chat. So as we move on to the next slide, let's talk about how we support this in our documentation. There's some general documentation requirements that are necessary. As with all reviews, these are components of general documentation that really must be provided to support your services as medically reasonable and necessary. So these general things include the physician history and physical, physician orders for the medication, including the dosing schedule, the practitioner's progress notes to give any additional information about the procedure on that day, the medication administration records or MARs, which include the drug, the dose, the amount, the date, the frequency. So remember those patients' 5 rights when you're documenting, that you have the right patient, the right drug, the right time, the right dose, and the right route. So make sure that is part of your documentation. These are things we're going to be looking for. There could be additional information that helps support a covered indication. And if that exists, then just submit it. It's better to provide more information than less. Finally, under general documentation, you must include a signature attestation statement if it's applicable. And if you've issued any advanced beneficiary notices, you must include those too. All right. Now let's expand those general documentation requirements a bit further. So I said before, you have to have an H&P, and that H&P and physician progress notes should support the FDA-approved diagnosis for which you're treating. It's not just enough to plop a diagnosis on the bill and call that covered. It's got to be noted by the physician, and it's got to be captured in your documentation. This includes a history for this diagnosis. How long have they had it? How has it progressed, et cetera. So these are things that are important to make sure you have captured in your documentation. As we stated on the previous slide, under the patient's rights, The dose of the drug given must be documented, and it must match the units on the claim. So when we're doing medical review, we have to ensure that the amount you're asking reimbursement for matches what you actually said you administered within your documentation. The amount of the drug given must also be in line with those FDA-approved dosing schedules, and the amount needs to be appropriate for the diagnoses that you're treating. So again, I had brought those up several slides ago about the dosing amounts and frequencies for various diagnoses, but please go back and look at those package inserts, look at the information on our website, make sure you're following the right dosing amounts and schedules. Next, your documentation must include the side the drug is being administered in. So is it right? Is it left? Is it both? So it's not enough just to have it on the claim with the modifiers, but your documentation needs to include that too. What side was the medication administered to? Was it right, left, both? As well as you move on and we start talking about frequency. So again, as I said prior, there are frequency and dosing schedules that need to be abided by. So when we review your documentation, we also need to see the history of the dosing. So this includes any prior amounts, dates, the side that they were administered on, right, left, or both, the diagnosis, so we can verify you're following the correct administration guides. So again, when we ask for documentation for review, if you happen to be chosen for review, and even if you don't happen to be chosen for review, make sure that your documentation is following some of these standards. Because if I request documentation for review for one specific data service, and you don't give me that history of prior dosing schedules and amounts, I don't know that you're following the FDA recommended amounts, dosing, frequency for this patient. So it could result in a non-affirmed decision or a denial of your claim. The rationale, if therapy is different from anti-vascular endothelial growth factor medications, like if you use a different medication for one eye than you do the other, or if you use a different medication for one injection and then you switch to another. So if there is a switch, or if there are two different types of medications being used, what is the rationale for that? We need to see that the physician documents the rationale. And finally, how did your patient respond to treatment? So when we're looking at your history, we're also going to be looking for the patient's response. The burden of proof for the continued ethical use of the medication comes down to you as the provider to prove. You do not want to continue to dose a patient with a medication that is offering no medical benefit to this patient. So you need to show by documenting how the patient is responding. Has the condition stabilized? Is there improvement in vision? Is there less pain, less swelling? Or is the condition continuing to get worse despite continued treatment? As I tell most of my classes, your documentation is the link between your delivery of care and the coverage of the service provided. It must support the need for and the delivery of the care that is provided. If it's not documented, it's not done. So also, be sure that if there are any other separately identifiable services that are performed on the same day, that you are billing those appropriately if you are allowed to bill them. And that includes the use of modifiers if it is allowable. So make sure you're checking to see if they are included as part of a global surgery or part of an NCCI edit, or if they require a modifier to identify them as separate and distinct. So this is going to take us to the end of our formal presentation. I am going to ask Jennifer if there are any questions in the chat, and I'm going to try to pull the questions over if I can get to them. But Jennifer, at this time, are there any questions?
Yes, Mary Sue, we have 2 of them so far. The first one says, can you bill an E&M on the same day as injection if treating both eyes? And she did clarify that not injecting in both the same day.
So I can't say yes or no that you can or cannot bill an E&M on the same day. The billing of the E&M is really going to depend on, if it's separately identifiable and distinct. So if it is, and if it is allowable, you can bill that using the appropriate modifiers. Again, you can't double dip for the services, so you have to ensure that all the services that compose that E&M are completely separate and distinct from the injection and the global surgery, of the injectant that you're giving that day. I will, if there is any more information on that, I will reach out to one of my teammates that specializes in E&M and see if they can offer any more direction, and I would send that out to all participants. All right, next question.
This is a little bit long, so let me read it for you. The question we always get is, at what point can we get paid for the medical decision making the provider is doing via an E&M exam done the same day? For example, the patient is there for a quarterly exam to reevaluate the plan of care in response to treatment. We decide the patient still needs treatment, so we treat them today and plan out the next 3 months of care. Bill the exam for extra work or no?
Well, let me see. I'm just trying to review the whole question again since it's kind of lengthy. Can we get medical decision making to providers doing E&M? So again, decide the patient needs treatment, to treat today for the next 3 months of care. I know, like I said, you can't double dip for the services. However, I am going to have to take this part back to Ellen, see if she can provide any additional insight. She is not able to join us today, so I am going to look into that. But if all the medical decision making that you are doing is really in response to the procedure, to the injectant that you decide to do that day, then it's not going to be separate and distinct.
Okay, I have another one, but she had some clarification. she had asked, is there somewhere we can find what is included in 67028? They are confused if they can still do diagnostic testing on the same day of injection if they are using the same diagnosis.
All right. So, is there, well, I guess for everything included in the 67028, I would probably start with your CPT and HCPCS coding books. That's going to give you the most amount of information. But I did say that I would pull this up and bring over our article about what's included in this upcoming review. So I'm trying to see if 67028, I do not think that information is included in here. And I don't know, let's see, I don't have that information right on hand in front of me. I don't know if anyone else online does, and I'm assuming Jennifer nor Rachel have all of that. But I would, Kimberly, I would go back to your CPT manual, and I would look up that code to get all the information on what's included. Confused. If we can still do diagnostic testing on the same day of the injection if we are using the same diagnoses. So can testing be done on the same date as the injection? Oh, that's a good question, Kimberly. Continuation. I don't know that that is allowable if you're using the same diagnoses. But again, we're going to look that up and we'll put that out to the whole group after this is done. Excuse me. I'm trying to scroll through as you are, Jennifer, with looking at some of the chat information. So if you have another question.
Yeah, Eylea, what code are you looking for? J3590 or J34? Oh, sorry, J3590 or J3490. Let me do that again. Eylea, what code are you looking for? J3590 or J3490?
So I believe the J3490 and the 3590 will be included, as well as the J0178. So the 2 milligram and the 8 milligram are both included. Let's say HD. Okay.
I'm seeing some more E&M questions, but I think that's probably something we'll have to send over to Ellen for her to clarify.
Yeah. Again, if these reviews haven't started yet, and so if there is a more specific CPT code that comes up because someone said there's not a specific one for the HD yet, if that comes about before these reviews start, obviously this article will be updated. And then you will receive notifications from our medical review department. They are going to reach out to any provider that they decide to put under review, and they're going to discuss exactly what they're looking for. And you're going to get a probe letter that's going to highlight what is going to be looked at. So again, if like unclassified information, unclassified drugs, get a more specific CPT code, this will be updated. Your letters will be updated prior to that. Documented. Oh, so other than the dosing, 2 milligram, 3 milligram, must the milliliters also be documented in the chart? I am going to tell you that it's always a good idea to document the milliliters as well. This person had said like Lucentis 0.5 milligram and then slash 0.05 mils. And right now I say, yes, do that, and that only behooves you to give the most amount of information you can, because if packaging information changes on these drugs, generics become available, et cetera, they may be packaged different. So we would want to ensure that you are giving the correct dosing amounts. Billing in same day. Okay, yeah, and some of these other E&M ones, I am gonna go ahead and take those, back and have my E&M associate help me with those. And I will put those out to everyone. And I apologize in advance that she was not able to be here. It was kind of one of those last minute things. But keep putting those questions in if you have them, because we are going to, again, take those after this webinar and get that information, and we'll put it out in an email to everyone. And so I think we've got everything. Is that correct, Jennifer, so far?
Yeah, I don't see anything else so far.
Okay. So again, that's going to take us to the end of our presentation today. Please follow up with any additional questions that you have. On behalf of myself and Jennifer and Rachel and all of Provider Outreach and Education, I want to thank you for your participation. We look forward to your survey comments and hope you will join us for future events. Your opinions will provide us with a better understanding of your needs and your preferences, and that allows us to tailor our future webinars to match your interests. So we genuinely value your input. So at this time, you may now disconnect.